Chairman, thank you. Doctors, perhaps this is for Dr. Hodes, and we've had a number of senators raise topics about dementia and Alzheimer's. What is the current state? What is one of the things I think, and I've told Chairman Blunt this, and we're in agreement, that one of the opportunities this subcommittee has is to highlight to Americans ways in which they can change their lifestyle, dietary intake. What's the status of the research in regard to dementia and Alzheimer's today that we would want every American to know in regard to their activities, behavior, and nutrition and diet?
Well, that's a very important question. Obviously, all of us, both individually and societally, want to make sure we're doing all that we can to decrease the risk of dementia and cognitive decline. And in fact, it's an important enough question that NIH recently commissioned a study on just this to ask what the level of evidence is for the kinds of interventions which might have that desired effect in reducing risk. It was released today, and I think some of your staff may have been briefed as recently as yesterday about it. The key words were that there are a great deal of encouraging, but in most cases, inconclusive evidence for what we can do. I can identify three critical areas and the implications for what we know now and what we need to do. One of them just alluded to was control of hypertension. So there is very strong association between hypertension and its control and the risk of Alzheimer's disease and dementia. As Dr. Gibbons mentioned, one study, SPRINT, was designed to look at the impact of aggressive control of blood pressure on multiple outcomes. And this is a case where, just as described, our institutes working together and using some of the Alzheimer's funding have supplemented that study to look at its impact on dementia. Those studies are ongoing. So it's an area of great promise where clinical trials such as SPRINT may give us conclusive evidence. But again, we'd have to point out that the evidence for the importance of controlling blood pressure and decreasing stroke and cardiovascular disease is so critical that it must be a part of our public health imperatives as we communicate. Another area is that of physical activity and exercise, once again shown to decrease the risk of death, cardiovascular disease, and where again there is suggestive evidence that it may play a role in decreasing risk of dementia. There are a number of studies, including some going on, as you know, at University of Kansas, we had a chance to discuss last year there, that are looking directly in randomized clinical trials to see what forms of physical activity may make a difference in lowering the risk of cognitive decline or dementia. And the other area is that of cognitive training, and one study supported by NIH some years ago showed that cognitive training was actually able to induce sustained improvements in cognitive function in particular areas as individuals aged. That kind of study needs to be extended further to see if it actually will have an impact on dementia.
What's the example of cognitive training? What is it that the studies suggest one ought to be doing?
There was a specific study that called ACTIVE, as its acronym, that looked at older Americans, men and women, who had normal cognitive function and trained them in either speed, reasoning, or memory, and then studied them over years to see the impact of that training. And it was an extremely positive outcome. That is, those individuals who were trained in those areas did have improved function over 5 and up to 10 years in that domain. What this recent National Academies report stresses, however, is that there is not yet compelling evidence for any of the other activities, including the computer-driven games, to identify whether they provide similar outcomes. So there are a good number of studies currently being supported. Another area where, thanks to the increased funding for Alzheimer's research, we're able to look to see what kind of cognitive interventions, as well as others, may play a long-term role in decreasing cognitive decline and dementia.
Doctor, thank you. In response to Senator Durbin's suggestion that NIH ought to receive more credit for its work, certainly want that to occur. One of the ways that Americans would really relate to NIH is, here are the things that if you do, the chances of your health improving or being maintained, there's a consequence to this behavior. And it is a way that I think you can tie NIH to everyday Americans and their lives, their worry about themselves and their families. Let me tie another topic that I care a lot about, Down syndrome. We've had conversations in the past in which Down syndrome and Alzheimer's, perhaps there's a connection. What's the status of our research in Down syndrome? I don't know who I should be looking at. I'll keep looking to my right. What's the status of that research, and what do we know about the relationship between Down syndrome and Alzheimer's?
Well, it's a very important area of research that probably begins with a genetic basis. The fact that, as you know, Down syndrome is associated with a trisomy, that is an extra copy of one chromosome, chromosome 21, which happens to be the chromosome on which the gene encoding amyloid protein and peptide lie. And reflective of that is, in fact, that as we have seen an increase in life expectancy with Down syndrome, it's a remarkable accomplishment over 30 years now, an average life expectancy not 30 but 50 and 60, that individuals at a relatively early age in high proportion are developing Alzheimer's-like dementia, both in terms of symptoms and in terms of brain function and structure. So both because this population now is one at a special high risk that is deserving of attention, and because studying this population is likely to inform all we know about Alzheimer's research, we have, in collaboration with the Child Health Institute, and again, using some of the funding that has been provided over the last fiscal years, initiated longitudinal studies in individuals over a range of age with Down syndrome to study what is happening in the brain through imaging and biomarkers to better understand and have a basis for ultimately intervening in these people, a highly vulnerable population, as well as learning more about the more general problems surrounding Alzheimer's type dementia.
Thank you very much. Thank you all for being so capable of speaking in language and terms that are reasonably understandable to me. Mr. Chairman, thank you. Senator Shelby, while the chairman realized you did that, I didn't even notice. Perhaps my final question is this, and I don't think we have the director here for this topic particularly, but let me hear from you. I've heard from parents, advocates of children's hospital directors, the difficulties in improving pediatric care. Treatments and new drugs are often developed with adults rather than children in mind. Establishing pediatric clinical trials is a challenge. So I'd like to ask these questions. Considering the difficulties facing this patient population, what work is NIH doing in research on pediatric issues? And what's standing between NIH and pediatric research that might restrict your capacity to have greater results and achieve what we're looking for?
Well, thanks. You're correct that the director of the National Institute for Child Health and Human Development, Dr. Diana Bianchi, is not at the table, although it would be great for you to have a chance to meet her. She's recently recruited from Tufts in Boston and is just a terrific leader in this space. But every institute at this table has some investments in pediatric research because of the way in which little kids become grown-up adults. But we also recognize that they're not the same as miniature adults, and they need special kinds of attention. The focus on pediatrics certainly has been a long tradition of what NIH has done. I might just ask two of the folks at the table to say something about this, maybe Dr. Lowy about pediatric cancer and Dr. Gordon about autism.
Thank you, Senator Moran. I would like to highlight three new programs which the NCI is initiating to support pediatric cancer research. As you may know, in the last 15-year period, there has been a 20% decrease in mortality rates from children with cancer, but there are two serious problems. First, some children who get cancer aren't helped. And second, the long-term side effects for children who are successfully treated can be devastating. So one program that we are initiating is part of the use of the Cancer Moonshot funds from the 21st Century Cures Bill, which is to develop new treatments for children with cancer. And as Dr. Collins mentions, childhood cancer is not just adult cancer in the small sense, but it's qualitatively different. And so it requires a separate kind of research effort, et cetera. So that's number one. Number two, with our regular appropriation that Congress has been generous in giving to NCI, we are also doing what we are calling the Provocative Questions Initiative, and that is to deal with vexing problems in pediatric cancer research. And number three, again, this is with the Precision Medicine Initiative in oncology, developing the pediatric match trial, which will be opening in the next few weeks, building on the success of the adult match trial. It's a paradigm-shifting trial which first brings the treatment to the patient rather than the patient to the treatment, and second, based on the molecular abnormalities of the patient rather than the kind of cancer that they have.
I just realized I should have also put into my quick response something about the ECHO program, which is a new initiative at NIH that we're very excited about. So ECHO stands for Environmental Influences on Child Health Outcomes. This is a trans-NIH effort to try to collect information on more than 50,000 children in terms of environmental exposures, in terms of genetic risk factors, following them over the course of time, bringing together cohorts that had previously been established but hadn't been connected or subjected to this kind of very careful scrutiny and standardized assays. Because there's still many things we don't understand about the role of the environment, maybe even in the prenatal arena, maybe especially in the prenatal arena, as well as in early childhood, in terms of how that affects such things as asthma, obesity, neurological development, including autism, and basically how it affects whether that child is healthy or not. We want to not just study illness, but also health. So ECHO, which is now just about a year on, and which is involving a very large number of components, including a Idea States Pediatric Research Network to basically be able to do clinical research, is our big investment that's new on the scene here to try to answer this kind of a question. Do you want to very quickly say something about autism? I'm sorry, I went on too long.
No, that's okay. So the autism is really not just a trans-NIH initiative, but it's actually a trans-governmental initiative. I chair the Interagency Autism Coordinating Committee that involves colleagues from really across the government, from the DoD, from the Department of Education, of course from the NIH, NSF. And our goal is to really try to understand and formulate a strategic plan for research around autism. I would say there are the three really exciting ongoing things that we're trying to do. First, we're really trying to understand what makes a difference in terms of interventions during childhood and how that translates into long-term outcome. Second, we're trying to get a better handle on on screening, particularly the younger and younger that we can identify people at high risk for autism, so that we can intervene earlier, and also so that we can learn more about what happens in these early ages. And the third is really recent developments in both genetics and environmental influences that really suggest things are going on actually in the womb. That's really where things are starting. So we're learning that we really have to understand early neuronal development so that we can really understand the risks for autism and do something about them.
Thank you for answering that question in a timely fashion such that Senator Shelby still owes me. I would conclude, Mr. Chairman, thank you, by saying this. One of the light bulbs that went off as you were describing this new initiative such as ECHO, one of the things that suggests to me that increasing funding for NIH research, there's always, science brings the new knowledge, which then causes us to look in a new area, and a new initiative arises, which suggests the resources are growing, the need for resources continue to grow. Very few things do we get to put the check in the box and say, we no longer need to look at this, but research allows us to say, oh, here's a new way, a new place, a new opportunity for us to find information through research and science that otherwise didn't exist. And so there's lots of reasons I've advocated for increased funding of NIH that never occurred to me that just your success in finding information breeds the need for more resources to find more information.